was once a guy who went to his local GP, and the GP says, "Sir, I have good news and bad news for you. Which would you like to hear first?" So the guy, being a natural optimist, says, "Hit me with the good news, doc." The doctor says, "Unfortunately, I'm afraid to tell you, you have just 24 hours left to live." "What?" said the guy. "That's terrible. That's the good news? What could possibly be worse than that? What's the bad news?" The doctor said, "Oh, I've been trying to get a hold of you since yesterday." Hello everybody, it's Ryan here again with our 45th mnemonic in internal medicine. This time we're talking about indications for acute hemodialysis and asking two other questions as well. But first, a scripture, guys. The book of Philippians chapter 2 verse 3 to 4 says, "Do nothing out of selfish ambition or vain conceit, but in humility consider others better than yourselves. Each of you should look not only to your own interests, but also to the interests of others." So you know, everybody, that our purpose in life is to love God and love people, to have fellowship with our fellow man, and to have fellowship with God. And I pray that will be the desire of our hearts, okay? Looking at indications for acute hemodialysis, the mnemonic is AEIOU, like your vowels, right? So A stands for acidosis, which is persistence despite medical treatment. So you give your show solution, you give your sotabic, etc. Acidosis is not coming down, right? E is for electrolytes, especially in the setting of persistent severe hyperkalemia despite medical treatment. Why is hyperkalemia dangerous? Because it can cause arrhythmias. And the various modalities we can use to treat hyperkalemia is the infamous potassium shift, right? Where you give calcium gluconate to stabilize the cardiac membranes, and you give insulin to activate the sodium potassium pump, causing potassium to move into the cells. And to prevent the patient from becoming hypoglycemic, you give your dextrose. You can also use Lasix, right, which will promote potassium loss in the urine. You can use K-Xylate, which is a potassium binding resin in the bowel. You can use beta-2 agonists, so you can nebulize with your short-acting beta-2 agonist. But if all these modalities fail, then ultimately you really do want to dialyze the patient. Intoxication with dialyzable toxins, that's the I. So here we speak to things like aspirin and lithium and methanol, which are dialyzable toxins. O stands for fluid volume overload. So O for overload. So you get a situation where the patient has renal impairment and there's persistent fluid overload despite medical treatment. And U stands for uremia in the way of pericarditis and encephalopathy, okay? So guys, another good question to ask is the renal failure in this patient pre-renal, or is it a situation of intrinsic renal failure, or a situation otherwise termed acute tubular necrosis, okay, which usually occurs in the acute setting, right? So ways to differentiate these entities is, first up, you look at the urea to creatinine ratio. Now, if you're using an SI unit of micromoles per liter, right, and if a particular value of the urea multiplied by 10 is usually greater than the creatinine if the situation is pre-renal. But in ATN, you take your urea value, multiply it by 20, it's usually less than the creatinine. Okay, that's one way. The second way, you should look at the increase in the creatinine, which is kind of like variable in pre-renal. But in ATN, it increases by less than 44 micromole per liter per day. Looking at the urinalysis as well, in pre-renal failure, urinalysis is usually normal, but in ATN, we get our heme granular casts. All right. Urine sodium is usually low in pre-renal failure. Okay, at a value of less than 20 millimole per liter, but in ATN it's usually higher at above 30 millimole per liter. The fractional excretion of sodium as well is a good thing to quantify. So how do we quantify fractional excretion of sodium? It's simply the urine sodium divided by the plasma sodium, that value divided by the urine creatinine divided by the plasma creatinine times 100%. And if the FeNA is less than 1%, we can reliably say that we're dealing with pre-renal failure. But if it's ATN, then the FeNA is above 2%. Another way is to look at the urine osmolality. Okay, if that value is above 500 milliosmoles per kg, it's pre-renal, but if it's below 350 milliosmoles per kg, it's ATN. Okay, and the other question we always like to ask in a clinical situation is, are we dealing with acute renal failure, or is this indeed chronic renal failure? So ways to differentiate those two entities is by looking, if you can trace in the patient's notes a previous creatinine which is more than 3 months old and has an elevated creatinine value, we can say with some degree of reliability that the patient has chronic kidney disease. Anemia as well usually speaks to chronicity of the kidney disease because of diminished erythropoietin. Okay, but not always. Small kidneys and ultrasound as well is a good clue. The exceptions, of course, being causes of large kidneys and ultrasound, which we'll discuss in another video. But suffice to say, diabetes, HIV-associated nephropathy, high VAN, amyloidosis, acromegaly, renal vein thrombus, adult polycystic kidney disease, bilateral hydronephrosis are a couple of causes. Renal osteodystrophy as well, like we discussed in our other video, why you get renal osteodystrophy. Right, and that usually speaks to the chronicity of the kidney disease. Findings on renal biopsy as well can be helpful. Okay, guys, there you have it. Indications for acute HD, AEIOU. and ways to differentiate pre-renal failure versus ATN, and how to differentiate acute versus chronic renal failure. God bless you and have yourself a fantastic day.